And I'm going to bring in, I think Neer Patel is here, definitely Jared Wallen, and give a little background about this wraparound thing, because when people think DPC, they think, oh, well, that won't work for everybody. And first of all, I'm talking to union organizers, which we'll hear from today. The working poor can afford $60 to $80 a month, which are what most of these DPCs cost. That being said, sure, there's mental illnesses, there's substance abuse, and you can spend all your money on alcohol. And I'm not, blaming, putting the blame on those patients for that. But the point is that it's a myth that people can't afford that. However, I do think that there is possibly some government role in subsidizing direct primary care potentially and giving autonomy to patients. But this is where the intersection happens with emergency medicine and specialty care, which is, well, what if something big happens? Even minorly big, right? Appendicitis. So how do we wrap that around? And I think I'll have to check with Neer Patel if he's coming on here, but I'm sure Dr. Wallen can jump in and get us started with a background. He's a urologist and started self-directed medical care to really spread the word about how this can work. So thanks for joining us.
Yeah, thanks, Mitch. Appreciate you inviting me to talk. Can I get a screen share option? Is that possible? Actually, it looks like I can. All right. So you were talking about wraparound. The first thing I want to just jump into, actually, and we've just been kind of talking about Stockholm syndrome a little bit. I think I kind of coined this term a little bit differently. United Healthcare syndrome, where people have this condition where they develop a psychological bond with their abusive health insurer. And I think that's unfortunate. And that's part of the barrier for us to getting, better places. But I think there's a large portion of opportunity there. And the reality is that, insurance, there's certainly options out there outside of insurance that can be very valuable for folks to essentially get free of the narrow networks, get free of the high costs. This schematic here just shows you the average annual premiums for a family. And look, basically you're looking at this on the left-hand side. This is traditional system or conventional system, however you want to phrase it. $5,500 out of the patient's pocket. Basically another $15,700 is basically, the employer paying for that portion. But remember, this is all employee money. Otherwise, that would be part of their compensation package. And then basically this up here, the average deductibles are climbing every year. So, I think the actual quote is somewhere around $25,000 out of pocket before people can actually get benefits from their care based on premiums and deductibles for the average family. This one shakes out a little bit differently based on these numbers. But if you look at different options, actually even a sharing community, which is in the setting of insurance where there's complexity and deception, sharing communities are actually very straightforward and very easy to deal with. And so you basically would cut your entire premium in about a half, and then your deductible would fall to $1,000, and you pick up a family plan for DPC on top of that, and you're still saving $17,000 with that type of setup. And I think that gives you, the DPC is great for the ability to offer day-to-day and even just try to keep you out of emergency situations. But the sharing communities or other options that are out there, level funded plans, I think that Neer will talk about and what have you, can be great for the catastrophic or major medical. And this is just a really side-by-side kind of powerful graph of the comparison of uninsured on the far left to a sharing community with Zion Health to traditional insurance. And basically, I don't want to take up too much time. I don't know if Neer is here yet or not, but basically, if you look at this, ultimately it ends up with a hospitalization, $13,000 for uninsured. You got some other costs along the way here and another hospitalization, and you end up, $29,000. In the traditional insurance, you're paying $15,000 in premiums, and then you have, another $6,700 in deductibles and co-insurances, and you're ending up for kind of the same stuff at $24,000. Whereas with the sharing community, you're looking at about, again, $7,500, about half of the premium cost for your actual coverage. And then basically, once you hit your $1,000 deductible, the rest of it is shared with the community, and you end up, basically in this setting, even over traditional insurance, you're saving like $13,000 throughout the year. I think the other beauty of sharing is that, you know, the reality is that the deductible or sorry, the initial unshareable amount, that similar to a deductible, it's not reset every year. And so, for instance, in a cancer diagnosis situation, it's actually, you have to be symptom free for 12 months before the essentially kind of quote unquote deductible or initial unshareable amount resets. And so from that standpoint, you know, basically beyond that initial payment, you would be kind of covered in perpetuity through whatever other treatments or what have you would need. So I think that's where there's a huge value. And I think the biggest value is it opens you up to be able to go see any specialist in the entire country and get care with them. There's no networks. It's all, you know, basically basically open access to whoever you want to see. And the other nice part about it is that if you do end up traveling somewhere, say you travel to the Surgery Center of Oklahoma and get a cash-based surgery or something of that nature, you know, the reality is that, you know, they actually cover the cost of your travel is looped into kind of the entire cost of things. So, you know, it can make it much more affordable and easy to get, you know, the highest quality care possible, you know, in non-emergency situations, right? I mean, obviously there's situations where, you know, emergently you have to get kind of more care in the traditional system. But I think, you know, I've heard people quote up to 60 to 70% of healthcare is actually shoppable. And so that's where this really leverages that to a large degree.
Thanks, Jared. Actually, it looks like I think Neer had we're probably off by a time zone, so he was able to jump in. But you know, considering I've had good conversations with him, you've had conversations with him, I'll kind of jump in. I'll play Neer for a minute. So let me introduce Neer, and theoretically he'll jump in here. So he's runs a direct primary care practice with his wife, who's a physician, and they started Virtuous Benefits, which is something similar to Mitigate Partners, which Christina Dewey had mentioned in the chat here. Now, Dr. Gold had really mentioned that it would be great to separate employer-based insurance altogether. Like, just we don't need that. And I think that would be ideal as well. And personally, what I do, and this is, I have my direct primary care physician, and you'll see Dr. Clota Ryan speaking a little bit later today. And then I have a health share. So I do use that. I use Zion. It's $120 a month with a DPC discount. And no, it's not insurance. And a lot of people start to get, you know, they love the devil they know. It's United Healthcare syndrome. I couldn't put it better than that, right? Well, it's not insurance. Well, how's insurance working out for you? And they're not legally required to pay in a health share. And I'm like, but insurance is, and they still find ways around it. And then you're still paying, you know, an incredible deductible or premium. So it's really just broken. So I do that personally, and it's one thing that's allowed me to speak out and be disconnected from a job, from an employer, an abusive employer, really, because that's what most of them are. So I do 120 plus 80 or plus like actually $60 a month. Dr. Ryan undercharges a little bit. We're talking about $200 or less a month. Everybody tells me they pay $200 a pay period, and then they're not getting access to a doctor, and they're still getting subsidized by their employer. And that means that money is coming out of their compensation package, right? That just because they're subsidizing it, it doesn't look as bad to you, but that's just money that's not in your pocket as far as your actual paycheck goes. So the thing I'll try to do, let's see if Neer's jumping on. I think he's going to jump on. He can take over after me. But to put this in perspective, insurance generally makes some sense when we have an unexpected catastrophic event, right? I mean, that's what insurance is supposed to work for. That's how our car insurance is supposed to work. If we get into a car accident, that, you know, in health insurance or in car insurance world, those unexpected events that we don't expect to happen is what that's for. But getting an oil change, which is expected, anticipated, there's no risk in that. There's 100% risk that you should get an oil change. That's more like primary care in some ways, and little minor, you know, replacement of your brake pads. This stuff is things that we can plan for, and the insurance model doesn't make sense for it. So what you have with United Healthcare and oh, great timing. All right. So I'm just explaining sort of how we're just jumping into insurance. And Dr. Wallen just gave his presentation. But what we're looking at right now is, our United Healthcare that we hate as physicians and we hate it as patients, but we still keep going to it. We need to get out of the mindset that we need it, at least in that form, because it is vertically integrated and non-transparent. And we always go back to that transparency. So there are these different solutions. One of them is a health share, which got a bad rap on with John Oliver and Last Week Tonight, because they just focused on the fact that it started in a religious from a Christian group, and there are a few of them that popped up and were predatory because it's a new market and it sort of happens that way. But there are reputable health shares, and the concept shouldn't be thrown out. Then there are real regulated insurance products. And one feeling is that because people have United Healthcare syndrome and they are familiar with insurance, that we might not be able to move the needle much. And Dr. Gold called it a unicorn, of completely disconnecting a wraparound health insurance product from employers. So what Neer Patel does with Virtuous Benefits is work with employers to get them off of their addiction to these non-transparent BUCAH plans that we consider Blue Cross, United, Cigna, Aetna, Humana, and those really that, I don't know, call them a cabal, right, of groups. So Neer, I'll let you jump in now. I'm glad you could join us. Get a little background of how that works, the components of the health plan, which really help break it down, and how people actually get their money back at the end of the year, essentially, if you have a put it in an HSA for the money that isn't used, whereas United Healthcare, it just goes into vague profit buckets.
Sure. Yeah. Thanks, Mitch. Thanks for having me. So what we do with Virtuous Benefits is, we help employers kind of learn a powerful strategy on how to sort of break free from this broken health insurance system. We start by kind of explaining to employers kind of what happens behind the scenes in health insurance, and health insurance in general, especially for employer groups, is very broken, very similar to how healthcare is broken, for patients and for physicians. So my wife's a family physician. We have a direct primary care practice in Austin, Texas, that we started 6.5 years ago. And I got into employee benefits and created Virtuous Benefits kind of to piggyback off of our practice, as it continued to grow and scale with employer groups, and as I sort of learned this strategy. But essentially, one of the main problems with health insurance is how the brokers are paid. They're paid a commission based on the premium amount. So that's the first kind of problem, major problem that exists, because in that structure, the broker is not incentivized to do the right thing for their client. They just aren't the way that they're compensated. Every year when they renew their client's fully insured health plan and they deliver sort of the bad news that, that health plan renewal rate is going up somewhere between 7 and 30%, and that's what happens year over year over year, they're actually getting a raise at the exact same time that they're delivering that bad news. And so, we need to shift the way that our advisors are paid, to make it more congruent with, doing the right thing for the employer and not for the insurer. The other problem that's wrong with traditional fully insured BUCAH health plans is the way that, essentially the transparency, right? If you're an employer and you take one of these plans and you start paying your monthly fees, you're essentially paying them into a black hole. And I say that because you have no understanding of what the insurance company is doing with your money. They don't tell you anything about what they're doing with it. They just take it. And the only real way that you can understand if you're actually getting any value out of this expensive benefit that you're paying for your employees is really by the renewal rate, because obviously there's HIPAA. We don't know our employees' health conditions, and we don't know if they're physically, their health is physically increasing with this health insurance plan that we're paying for them. But we can tell by the renewal rate, right? If everybody was getting healthier, the renewal rate should stay flat or it should start to decrease. And as I mentioned, What's actually happening every single year over year over year is it's going up 7 to 30%. The insurance companies would love to raise it 30% every year. They would love to raise it to the maximum, but the healthcare law doesn't allow them to do that. They have to have supporting claims data in order to justify their increases. And that's an important point to note that I'll come back to in a little bit. So now, so we have no transparency. We don't know if our employees are getting any healthier, and we just keep paying the money and we keep getting 7 to 30% increases. So that's essentially, everything that's wrong with sort of the broken health insurance system. And so what we do is we teach employers a different strategy. We move them from fully insured to level or self-funded health plans. Essentially, it's a self-funded health plan. And that term, I think, has some negative stigmas behind it. And a lot of people make assumptions and presumptions kind of immediately when they hear the word self-funded. They kind of think, well, this is just for huge companies like Apple that can afford to fund their own claims. And that's definitely not the case. And especially with, everything that's out there with direct primary care now and even direct specialty care, we have an amazing alliance of practices that are all over the country that are incentivized to take really good care of their patients and not do unnecessary things and not overcharge them and shield them from the broken healthcare system. And so what we do in our health plans is we utilize those practices. So just kind of going back to the differences between self-funding and fully insured, right? So fully insured is everything that I just kind of mentioned, all the brokenness, and self-funding sort of contradicts everything that I just said. So the first thing is on fully insured plans, when you go to get a quote, your broker is going to go take a spreadsheet of your employees' names, birth dates, and zip codes and go get a 30-second auto-generated quote from the 5 BUCAH insurers. And those quotes are all going to come back high automatically because the insurance company doesn't understand anything about the health conditions of the group. And all insurance is risk mitigation. So they're determining what the premiums are based on the risk. And since they know nothing about the risk, which is the health of the group, they are going to rate those premiums extremely high. So what we do on the self-funded side is we underwrite our plans. So we take into account the health conditions of the group of employees. We do that one of two ways. Either we use health questionnaires that the employees answer, a 2 or 3 page questionnaire, just kind of looking for the big things, any hospitalizations in the last 5 years, any major surgeries, any medications that they're on. We're basically disclosing the health conditions of the employees to the insurance company up front. And so what they're doing is they're underwriting with that information to say, okay, we're going to determine what the risk is based on the health of this group, and we're going to rate those premiums accordingly. And when we do that, the presumption is that people who are able to work are generally healthy. And so when we do that, we're able to typically get a much better rate. So, that's the number one difference, is that the premiums are rated on something logical in self-insuring versus something illogical and fully insured. And then once we get that quote, once we get that underwritten quote that an employer can actually take, that piece of paper is going to be completely transparent. It's going to help the employer understand where every single penny of the money is going. So, they basically show a projection of kind of what the annual cost is of the whole health plan based on the premiums that were decided based on the health conditions of the group. So we can see the total amount of money that's coming into the plan for the whole year. We can see what the fixed costs are. So we work with independent vendors to do their, everybody has a role that they play within the health plan. And the BUCAH health plans do this as well. It's just all buried in the background and they don't disclose any of this. So we are using our own vetted independent vendors rather than allowing the BUCAHs to create their own network that they assemble with their vendors who have sort of astronomical markups on top of markups on top of markups within every single aspect of the plan. And so in our structure, we're using all independent vendors that all have transparent and reasonable fees for their role that they're playing in the health plan. So one of the major things that a BUCAH does with the health plans is they manage and administer claims with the employer's money. And that's something that people don't, necessarily realize. I think they think that there's some magic pot of gold where all this insurance money comes from. There isn't. It's, employers pay for their own healthcare, and, and the insurance companies have every single algorithm figured out to make sure that they collect more than they pay out. And that is how they're continuing to make hundreds of billions of dollars a year off of all of us. And so, so that's what we do is we underwrite, we get a transparent quote, we have our independent vendors. So those are all the fixed costs. So we can see the total amount of money that's coming into the plan from premiums. And then we can see exactly what the fixed costs are. So you can think of a direct primary care practice as one of those fixed costs, right? One of those independent vendors. That DPC practice is going to take really good care of every employee that is part of that company. They're going to handle about 80 to 90% of all of their healthcare needs under the DPC's affordable membership fee. And they're going to, by doing just their natural job that they do, they're going to steer all of these unnecessary claims away from the health plan. And so after the fixed costs are paid, we know that those fixed costs are money that's never going to come back to us. After those costs are paid, the rest of the money that's paid into the health plan, that's all sitting in the health plan, and that's being used. The third-party administrator that we hire to manage and administer claims is going to use that money to fund claims that happen throughout the year. Since we have a DPC doctor taking care of about 80 to 90% of all the employees' healthcare needs, and we're steering all these unnecessary claims away from the health plan, the likelihood that there is a significant surplus that remains in that health plan, we call it the claims fund, becomes very high. And the powerful part about our strategy is that we refund that money back to the employer at the end of the year when it's not used. And so the DPC practice is really critical in our strategy. It's not required, but it is very critical in not only physically increasing the health of all of the employees and giving them amazing access to a fantastic physician that they know and trust and create a meaningful relationship with, but that DPC practice is also protecting all of the money. So they're protecting all of the claims fund money, and they're also protecting the renewal rates, because like I said before, when I asked you guys to note about the insurance companies, needing to have supporting claims data in order to raise their renewal rates to maximize their profits, they would like to have as many claims as they possibly can. The more claims that they have, the better off they are in maximizing their profits. It doesn't seem logical, but that is what goes on. So by us not allowing them that leverage to have, basically to make us think that we need to file a health insurance claim for every single thing we do for our health, it's no different than you filing in a home insurance claim for every small single thing that happens to your house, right? It's exactly the same thing, and health insurance is no different. It's all insurance. So by not allowing them that leverage and significantly reducing the claims, we're not now getting them to the point where they don't have the leverage to increase those renewal rates, to those maximum levels that they want to. So we get our employer groups to the point where they start having their rates remain flat and even decreasing year over year. And that's in a very quick nutshell, the sort of the strategy that we teach employers all across the country.
Thanks, Neer. I think we actually built in more time than I thought in this, which is good because I got nervous with time yesterday. So I think we can kind of take questions and comments. Jared, did you have?
Yeah, I was just going to say a couple of follow-up comments between what you said and Neer said. I think the one thing to note, I know you kind of mentioned the common things with sharing programs that people get a little bit leery about as far as the no legal, kind of requirement to pay. I think the reality is where, I think insurance, again, part of that United Healthcare syndrome where we're kind of fleeced. We pay $25K on average out of pocket for a family before we ever get any benefits. And we don't see transparency. And I, remember part of the reason that the costs are so inflated, like Neer was talking about, the markup discount game that happens in retail, just like it happens in, you know, hospital and insurance systems too, right? And so that's part of the way that they get around some of this 85% going to paying for care, is that they inflate the costs. I mean, I think, you know, what that Wall Street Journal article recently, a couple months ago, was, you know, either $6,000 or $60,000 for a C-section at the same hospital, depending on which insurance card you set down. And so the reality is, I mean, that'd be like paying for a Big Mac. You'd either pay $6 or $60, and you wouldn't find out till 3 months later, depending on which credit card you laid down. And so, you know, the reality is that's one of the ways they're marking this up and really making more money. One of the other things I just want to kind of to piggyback on, you know, Marty McCary's book, The Price We Pay, is great. I'd certainly recommend it to anybody who's interested. But he was talking about how these insurance brokers, not only do they get, you know, commission rates, they also get kind of bonuses and quote unquote kind of kickbacks. And they also sometimes can get penalized if they kind of lose business for these companies, right? So that's a problem. You know, I think actually, love him or hate him, Robert Pearl, the plastic surgeon, I think out of South Florida, actually wrote an article about how healthcare is somewhat similar to the 3-card Monte card game, where, you know, to some extent, the main portion I want to highlight about this is that we were talking about this employer portion of the premium. And remember, that really is actually part of your compensation. It's really all employee money. But, you know, to some extent, that's also hiding a lot of the costs, right? Because your employer is, I mean, yeah, you may feel like you're paying, you know, $500 a month as a patient out of your paycheck, but your employer is actually probably paying 70% more than that on top of what you're paying as well, right? And so it really kind of puts another layer of opacity in between truly understanding how much you're really kind of paying each month out of the premiums and such. So, you know, I think that's huge to really try to help people understand, is that, yes, you may only see $350 to $500, but your employer is probably paying another $1,200 a month for you. And again, I think, you know, especially with sharing or some of these other like programs that Neer and other folks have, you know, the reality is that, I mean, you can probably pay half of that and get better care and more access, and especially when you couple it with a DPC and what have you.
Yeah, I have to throw that one in there. That's what everybody always says when you mention DPC. They say, "Oh my goodness, well, why would I pay for that on top of my insurance?" Well, it's a good question. Why would you? Because your insurance is crap. So you want to take that, you want to change that to something else, and you really can cut out a lot of fat and get better care. So I wanted to bring up Christina Dewey's question, and maybe I'll frame this a little bit here, because I think she's bringing up it. So somebody has if somebody's sick, if the employer base is sick, and I use that term very broadly, maybe they're very functional, but they have routine healthcare costs, or chronically ill, or have a high risk, they are rated as a high risk, then it sounds like, you know, it's still going to be an expensive premium. And just like you said, there's no pot of gold, there's no made up money. Now, what I think we could say is that if we as a society spread that risk truly across the entire population, we can subsidize those sort of sicker people. But we're talking about spreading that risk across an employer base, because that's the weird system that we have, and we're all used to that, and employers provide benefits. So that's where the level funded plans come in. So they're not perfect. If everybody in the employer base were to need a biologic, they probably wouldn't be eligible for that, and you'd probably be getting your money's worth out of a BUCAH plan, would be my guess. So if you can put that into context, though, because a lot of these employers will have like one or two, or a few people will have inexpensive medication, and we can't necessarily fix the corruption of, we can fix some of the corruption of the PBMs, right? Because you're getting a nice, transparent, independent PBM, but you can't fix the corruption of pharma, or just the fact that some medications legitimately are expensive. But there is some mechanisms that you have for that, right? If there's a couple of employees with expensive biologics or something, if you can explain that to us.
Sure. Yeah. So, so yes, again, the on self-insuring, it's all dependent on the health conditions of the group. So if the group of employees is unusually unhealthy, and there are a lot of people with major things going on, sorry about that. If there are a lot of people with major things going on, you know, we have creative ways of kind of making those submissions, right? So, and especially if the group is already on a fully insured plan. Fully insured plans can be started and stopped at any time, and employees can be added and removed at any time throughout the year. There's no rules or regulations around that on a fully insured plan. So, you know, we can leave a lot of those people if we know those conditions on the fully insured plans, and then we can sort of slowly move them over to, you know, to our self-insured plans over time as, you know, as they get healthier, kind of working with more closely with, you know, a direct primary care type physician. And then as far as the medications, yeah, the specialty medications, the biologics are usually the issue. And it's the same situation with biologics that it is with kind of every other drug, right? So biologics, generally speaking, are more expensive. However, they are not as expensive as we are making them seem that they are in the US, or the price tag that we're putting on them in the US. So there's plenty of kind of options out there depending on a lot of different factors. We can look at manufacturer assistance and help the employees, you know, with that. And we can also look at sourcing those medications from outside of the country. Canada, Europe, those medications can be sourced. The biologics that are the brand names can be sourced typically between 50 and 90% less than they cost here in the US. So there are a lot of different ways that we have to be able to build into the plan to make sure that sort of everybody's protected and that everybody's getting the care that they need.
I want to bring up Dr. Dewey's point. So I really do think that's the case, right? Like I'm working on this book, and we'll probably end up coordinating in some way, Jared, you know, as how to hack your healthcare. So it's like, unfortunately, in America, you do have to jump around to like, you have to be agile and, you know, work around a broken system. And so getting all the tricks on how to do that in one place, including going to Canada, honestly, because you really can get good Canadian medications like that are the same in the United States and well regulated. And it's technically illegal, but the federal government just doesn't care because they know that people have to do this. And so they don't really enforce it, is my understanding of that. So Christina, what you mentioned, and actually I have this, I don't know if you have these, there's a few Canadian pharmacies or pharmacy checker, and you can compare.
I don't think there's anything unlawful about it. I've never heard anything like that before.
I forget where I read that. I thought that it was basically technically illegal, just like never ever has been pursued. But I mean, corporate practice of medicine is illegal. They're not enforcing that one either. What are the laws mean in this country?
Yeah, there's plenty of self-funded plans all over the country that are sourcing biologic medications from Canada and other countries.
I wanted to bring up Dr. Dewey's point. So right now, in a sick workforce, I mean, employers don't want a sick workforce because they're going to take off time from work anyway. That's a classic thing. But if they're all right now paying the same amount, even if it's a ripoff for a BUCAH plan, would this make the employers think, oh, well, I can't get this lower cost health plan because I got this expensive employee, so let me terminate the employee? Is that something you've run into?
No, you know, like I said, if we know that there's sort of one employee that's kind of bringing everything down, and you know, I mean, you can actually get completely declined. So it's not just, you know, you have to worry about a huge rate increase. It's that you have to worry about, the insurance company would just say it's too risky and we're not interested. But again,
from that perspective, would that mean that the employer might start thinking in the back of their head, oh, well, if I just get rid of these employees, I'll come back here and I'll be able to cut my healthcare costs down. I mean, I suppose that's a risk that you can't completely get around.
Yeah, I don't think that I don't think that you can control, you know, if somebody has that thought process in their head, I don't think you can control it. But what you can do is educate, right? And so that's really the goal of a good advisor, you know, a good benefits advisor, is to educate the employer on kind of how this should all work and how to do this properly. So, you know, when we get our health information from the employees that we review, you know, and we set up our submissions accordingly on how we're going to submit to make sure that we get the proper rates. We keep some of those employees that might be bringing the whole group down on fully insured plans, and we bring them in slowly if we need to. And that's kind of how we get around it.
Fair enough. And we all know that there are unethical employers. I mean, that's what we're fighting against is Envision and Team Health. So I don't know if we can fix all of that. The other
one important point, if I can interject real quick, I think the reality is, I think Neil kind of, Neer, sorry, alluded to it a little bit, but I think the reality is if you have more consistent primary care, like a direct primary care relationship where you can see them as many times as you need, or even touch base with them 4 or 5 times, 6 times a year, rather than maybe once or twice, people tend to get healthier in that setting, right? And so from that standpoint, you can kind of start to hopefully mitigate some of that, and allow those people to kind of progress, into essentially kind of gentler financial plans.
Yeah. Direct primary care, again, I can't stress enough how critical it is to this strategy working. And I don't think I would be in insurance, nor would I be recommending moving to self-funded plans if there wasn't as vast of a direct primary care network as there is. And I'm sure Dr. Gold has already talked about direct primary care, but the bottom line is primary care in the insurance world, those doctors have 5 to 7 minutes to spend with every patient. It doesn't matter what Ivy League medical school they went to, there's no way that you can possibly diagnose and treat a patient properly in 5 or 7 minutes. And so a lot of times you're giving unnecessary medications to get them out the door, and you're giving unnecessary referrals that's for something that you could handle if you had more time. And the reality of the situation is that's a lot of what's going on. We as a country don't think that family doctors really do anything anymore because of how diluted the insurance companies have diluted primary care so severely, for the reasons I just mentioned.
There's some great questions coming in. I'll get to Brad's in a second here and go back up to Dr. Patel, Tarang Patel, who's Dr. Money Matters and spoke yesterday and will also be participating today from more of a personal finance perspective, and brings up what are people's thoughts on the Silicon Valley medical groups like One Health and Carbon Health, which I haven't heard of, that claim to sort of be DPC. Iora Health, speaking of Marty McCary, he had really expounded on Iora Health. And, I don't think he quite gets the mid-level issue, to be honest, because he loves the idea of everyone else doing everything and the doctor being in the background. And I think that might be more of a surgeon sort of mentality. But he talked about Iora, and I loved like the health coaches and stuff like that. But Iora sold to One Medical in an all stock transaction. And One Medical, if I recall, I don't remember if it's Apollo, but they have private equity backing. And One Medical is in the process of their staff is unionizing. And I believe their visit format decreased when they had like an IPO, or they decreased the amount of time the physicians and providers could spend with the patients. And so I don't see that going anywhere else other than, as Dr. Josh Umber says, jumping for a physician or a patient, jumping from one frying pan to another. It's not direct. I don't know if you guys have different thoughts on that, or.
I completely agree. When we build health plans for employers and they have employees spread out across the country and we need to utilize our colleagues, I do very extensive research into the DPC practices that I bring into our health plans to make sure that they are sort of, like-minded to our DPC, which is we are completely independent and completely non-corporate and genuine in what we're doing, which is taking really good care of patients. At the end of the day, as soon as you start having all of these administrators and business people trying to, get their hands into a primary care practice, everything falls apart, and the philosophies and the principles of good primary care become lost. And that's not what we're interested in, and that's not what's going to help fix the problem of this country getting sicker and sicker and sicker, even though we spend, one of the countries that spends the most money on healthcare.
Yeah, I think that's a great point. I mean, I think to piggyback that, the reality is that big business will probably never solve these problems. They, obviously consolidation and what have you just drives up costs. and it really doesn't get you that care. It sounds like it's really just another hamster wheel for the healing team, and you're probably going to be pressured into shorter and shorter appointments, and that's not really where the value is, right? The value is relationship-based medicine, where you have 30 to 60 minutes to really focus in and try to fix some of these things and help people. And obviously, just like United or all these health systems and such, I mean, there's like, I think 11 pharmaceuticals, 5 health systems, and 7 insurance companies in the top Fortune 500 now. They all have shareholders that they're beholden to, right? And so from that standpoint, I think that's one of the values of independent healers, being able to not have that pressure. I think that's also essentially, to some extent, kind of one of the values of sharing. There's no shareholders there that are driving 400 to 700% increases over 8 years in stock prices for profit, right? And so from that standpoint, that's, again, I always tell people the highest quality, most cost-effective care is between you and an independent healer, because otherwise there's too many predators in the way.
I was trying to look it up. I can't remember Forward, the other sort of DPC thing where they have it's like you step into a booth and it's their magical scanner thing from Star Trek, and it's like a scale and a pulse ox and a blood pressure cuff, but they dress it up and make you feel really special. And I don't want to misquote it, but their founders, I believe, are from like DoorDash or something. Like they're just app companies, that are doing this. So, and I agree with Maureen about no one who takes Silicon Valley VC can be trusted. I mean, VC can make some sense, or some angel investing and stuff can make sense to get some things started or to innovate. There's no innovation going on in this, like in staffing. The only innovation is in how do they extract more money for shareholders. That's my personal view on that. Brad put in a lot of thoughtful comments here, and it is a really good discussion to have about, looking abroad, right? We always look at this, and I think one of the best introductions to this I had was Sick Around the World. I think it was a PBS documentary special, and they just pretty unbiased, I felt like, view of let's go to England, and they're like, well, this is a bit of a nanny state, and but that's the most socialized it gets. It's everybody's a government employed, right? And then they went to multiple other countries, and you look at countries like Taiwan, and they're like, oh, well, this is actually in Germany, and there are actually public-private partnerships that are functional. All of them are more functional than our systems. Now, I don't know if DPC is an alternative approaches to insurance are a fundamental part of health services internationally, but I think some of the concepts are. People go to other countries and then they go to the doctor and they realize, wow, I only got charged $20. And it's like, probably because you were not getting ripped off, and that's actually the cost of healthcare, which is similar to DPC concepts. But the government has probably been a little bit better in subsidizing or promoting these transparency concepts and promoting a functional health insurance type system. So I'm not sure your perspectives on that, if anyone knows if sort of direct primary care is a concept. It is clear, Brad says that countries that are top performing invest in primary care systems. Well, we don't, and I see DPC as sort of a way that doctors are taking it into their own hands and saying this country has failed to invest in a primary care system, so we're going to change it on our own. But I'd love your guys' perspective on that, and if you have looked abroad, it's a big world, and it's not just Canada and England out there.
Yeah, I don't know too specifically about how the different things play a part abroad, but again, the one thing that I would say too is that when you look at these newer companies that are kind of coming into the space from Silicon Valley and such, I mean, the reality is that there's never going to be that quality there, and there's always that pressure for profit, and it's just not there with I mean, obviously you have to make enough money to keep the lights on and such as an independent healer, but you really don't have to scale billions of dollars for shareholders or what have you. So I think that, you know, DPC, I mean, I think, you know, anything that's run by the government, even anywhere else, is somewhat questionable, because ultimately somebody's paying for it somewhere, and most of the times that's the taxpayers, right? So you're paying for it one way or the other, whether you really kind of understand the financial part of it or not.
Yeah, I mean, it's true. There is no such thing as sort of a free lunch. But, you know, I wonder if other countries have figured out how to do it more transparently and efficiently, or, you know, what I would love to see, this is just my personal opinion, that we could, knowing that there is such inequity in wealth, especially with private equity super concentrating it and creating more poverty, is I think we do have to redistribute some of that wealth. But if we give it back in terms of a transparent, you know, almost like a universal basic income, fully fund an HSA without requiring people to have an employer-based plan to get an HSA, or a BUCAH plan through the ACA to get an HSA, then you can allow patients to value that money, spend it appropriately. This is what Dr. Gold mentioned with like EBT cards. You know, we allow people to make their choices about what food they're buying, even though we subsidize it. Anyway, I know this is probably a little beyond the scope of what's going on here. I think we're just doing everything we possibly can to bypass a broken system in the United States, and these are great options for it. Go ahead, Brad. Let's have, if you want to jump in with your comment.
Yeah, and this is coming from both experience, study, and then also this article was actually thrown out just by Paul Barish, who's worked in other parts of the world as well and lived in Australia, et cetera. But if you're looking at our health system performance rankings, we are the last for all the developed nations across the board. When you look at places like Australia and others, New Zealand, they have multiple tiers. There's a basic level of government-sponsored care for everyone, and then the ability to have your DPC model, right? And because healthcare there, it comes out, everything's pre-tax. That's the beauty of it. It's not felt by our pocket, and the cost of implementation is much less, because this is not a profit motive so much. They do have some privatization, as we heard yesterday in radiology. Private equity started actually in Australia, so there's no panacea. But the fact that that your primary care, your management, your diabetes, your hypertension, your preventive care is all guaranteed, not just payment, but access, right? And then if you want to be bumped up in line for getting your hip replacement, you can pay extra to go to a private hospital for that. But those services are available at the public system. And they've created the checks and balances to make that work much more effectively. And so the parts we're talking about, and I really appreciate both Jared and Neer's presenting, like they're all constituent components that most of us haven't thought about because we've been so ensconced in our corporatized and then employer-based funding models, right? Like, and it's time to break them apart and figure out what do we want our population to look like. And I think, as Terry so aptly noted yesterday, there's a pre and a post-COVID time, right? And we have the opportunity to move forward and actually think much more thoughtfully about what we're getting for our dollar and how are we going to keep the access available, because we need to actually have our healthcare workforce be practicing the way, for the reasons they went into healthcare and medicine, but also in ways that are consistent with actually having a beneficial outcome at scale. So thank you all very much.
Thanks, Brad. You know, I don't want to put our presenters even on the spot here, because this isn't the how do we solve the entire world healthcare system, right? Or what is the exact right model? I love this because it gets us thinking outside the box now, because what I've seen is that there's like a false dichotomy in presented to us by Congress, to be honest, and politicians, which is basically we go Medicare for all, which guess what is going to be United Healthcare screwing everybody for all if we have this current system, or we keep our private system. And that's the classic Republican approach, which is you get to keep your private health insurance, which means you get to keep United Healthcare. So actually, I think that United Healthcare is just controlling the entire discussion behind this. There is a very valid discussion, and this is how I got into this in the first place. Back in undergrad, I was my major was health science, and I interned at the Commonwealth Connector, which is the precursor to the ACA, right? So my background here at least is in understanding exactly that health policy. I'm not an expert about every system in the world, but we do very much know that every other developed country somehow provides better access, even if it's not ideal, and doesn't bankrupt its citizens. Like, they have done it somehow. I'm not sure. I mean, I'm starting to think that if we funded the ability for patients to go, find a private doctor, but it's all transparent, which is basically funding an HSA with DPC, and then a wraparound, that might be better than many other countries actually have right now. If it's just a public program and you go somewhere, because I could see that turning into a bunch of nurse practitioners that the government employs, with a veneer of healthcare. So I don't really know. I don't have the answers for that. But what I really want to get, again, in putting this together, is get people thinking outside the box, and maybe doing this for their own families right now, and then raising those authentic voices up when we have these much bigger discussions, in a larger stage, maybe at next year's summit, maybe with free to care, maybe we move the voices within the AMA, et cetera. So with that, I'll let you guys close with some final thoughts here. I got to make sure our next presenter is around, and we can take a couple comments if are still any. I see Mo and Terry have commented in the box too.
Yeah, just to throw a few comments out there. I think, the reality is one of the dangers of these Walmarts and Silicon Valley corporations getting involved too is, Dan Kennedy, who's a famous marketer, business guy, is quoted as saying the business that can spend the most on marketing to acquire a customer will win. And so, that's something I think as physicians we're classically bad at, is marketing ourselves and getting the word out there, which certainly needs to be done, because obviously that's, part of all of this, right, is educating folks and getting them understanding what we're doing. The other thing is, you mentioned kind of bankruptcy, and obviously medical bankruptcy is actually the #1 cause now in the United States of bankruptcy. Is 66.5% of bankruptcies overall. That's like 500,000 people a year, 300,000 or more. So 60% of those folks actually have insurance. And you also mentioned kind of hospitals kind of being predatory and suing folks. Actually, again, in Marty McCary's book, The Price We Pay, he mentioned that in 2017 alone, the state of Virginia, there's only 37% of hospitals that actually sued patients, but out of those, they actually filed 20,000 lawsuits that year alone. And so it just shows you, and again, some of these hospitals that are suing are nonprofits, and they're supposed to be delivering charity care for their tax exemption. And I think there was that recent study that showed that they're actually delivering less charity care than some of the private and public hospitals are. And so, it's a darn shame.
Thanks, Jared. I think Terry might have his hand up. I'm having trouble figuring out this.
Yeah, it says Terry.
But Terry, feel free to jump in and chat. And then
can you guys hear me?
And then we should have time for one more with Dr. Newman.
Yeah, can you hear me?
Yes.
Yep, we can hear you.
Okay, great. Well, I really appreciate this commentary. I never learned anything about the business and economics of healthcare until well after medical school, after residency. And it does take a little while to dive through it, but like a lot of things, once you learn about it, it's not as complicated as you think. There are plenty of countries, dozens and dozens of high-income countries that have figured out how to pay for very high-quality modern healthcare, sometimes more modern than our healthcare, without resorting to the insane profit gouging and inequalities and inequities that our system creates. And so, the way I think about this is, the healthcare dollar has to be gathered in some way, whether it's national health system or national health insurance or private insurance or the sick pool model, the Bismarck model, where you just take a little piece of everybody's taxes. And there are only about 4 or 5 different major ways to collect this money. But once the money has been collected, whether it's private or public or government or some combination thereof, you have the vultures and the sharks who then come and attack and try to gulp down that money for their own interests. And I think that's what has really happened with our own private health insurance, pharma, hospital system, CMGs, PE. These are all kind of sharks attacking this dead whale. That's the practice that really needs to be protected against or prohibited.
Thanks, Dr. Mulligan. And yes, your background in international health, and we have several here, I think as this conversation develops will really be vital in having like the real discussion, not the entrenched interests in DC creating a false narrative with a bumper sticker discussion. That's how I look at it. Let's in Singapore, yes, Singapore's Bismarck come up all the time. I love that stuff. Let's have Dr. Newman. We've got 3 minutes, just have a final comment and some discussion on that. And then let's bring this energy to the panel later on, because we will have a lot of robust discussion there, where we move forward. And I didn't come here to completely solve the US healthcare system, but we're going to have a lot of good minds being put together from different fields that haven't come together before. So we might get somewhere. Dr. Newman?
I think one population that we tend to leave out of the conversation altogether is the public. And the public has made a lot of change in society just by raising their voice, but they have to be educated, because I do believe in people being accountable. We talk a lot about being advocates, and we are, but patients also have to advocate for themselves. We just have to give them the tools, the information. We have to, inform them of what's going on, let them, and that's what I liked about the room I was in yesterday with Bradley Schwartz, that's the conversation we were having, is how do we make the public and the patients aware of what's happening? And then how do we basically teach them to advocate for themselves? So in a way they can assist, they can help us help them. And that's a lot of what I do on Twitter, which is to educate the public. So a lot of mid-levels and stuff are blocked. If I see NP, if I see PA, I just block them. I don't even try to have a conversation because I'm just there to educate the public in terms they understand, and then inform them about what's happening and tell them what their options are if there's a bad outcome because they weren't informed about something. If they're not told when they go to have surgery that the person administering their anesthesia is a CRNA, and they think all along it was a doctor and something untoward happens, then they do have recourse, and we tell them that recourse. But I also think that a certain amount of common sense needs to be applied, and I don't have a problem telling people that, because if they say, well, I wanted to go to Walmart because it was cheaper, they had a really good deal, I said, okay, I want you to put this in context. You're going to a retail grocery store for your medical care, and you mean to tell me that that sounds perfectly logical? You think that sounds safe? And then you wait for them to respond, and it doesn't sound safe. It sounds stupid, because it is, and so it's just as stupid as what Dr. Keeney said, that, ACEP and all of them promote board certified ER physicians. And frankly, somebody's got to pay those dues to keep them alive. Okay. So we're going to go through the whole process and jump through those hoops. And then you promptly continue to hire mid-levels who we now no longer really need, because the excuse was that we had a shortage, but now we know we're not going to have one. And now they're trying to find a way to finagle that in. And really it's just to say, for them to make a profit. But it's just a slap in the face, because you promote board certification, but then once the doctors get out there, you don't ensure that they have work and that they're secure or anything like that. And so I didn't want to say it, because we keep talking about let's AAM and ACEP get along. Let's all get along. Can we all get along? And now I'm going to say it. I'm just going to be blunt and say, no, we can't get along. Okay. I left ACEP for a reason, and that's not going to change. They got 23 years of my funding. So yeah, I can talk shit about ACEP because they got 23 years of my funding. When they give me my money back, I'll shut the fuck up. Okay. So once they paid for emergency nurse practitioner program, that was it for me. And they were traitor trash. So somebody can, whoever's taking the notes, document that. Yes, I said it. And excuse my cursing for those who are out there. I'm a Christian, but I'm a cussing Christian, and God forgives me. That's
Oh
it.
my goodness. Thanks, Dr. Newman. Thanks, Dr. Wallen and Neer, Patel. Thanks, guys, for jumping on here. I hope you guys stay later for the panel discussion. And I really think we're going to have some solid, good thinkers in that, and we'll get some good things will come out of it. And thank you, Dr. Newman, as always. And I'm hoping somebody tweeted all of that.